Hello everyone. Welcome to our deep dive into malaria. Our objective today is to provide a thorough understanding of this disease, exploring its impact and the various prevention strategies currently employed. We will examine the complexities of malaria from its definition and the global burden it imposes to the intricate details of its life cycle, all the way through to current treatment paradigms and the very latest in vaccine development. This presentation will be comprehensive, reflecting the critical importance of this topic in global health. I am Docsaab and I am committed to provide you with the most current and accurate information available on malaria. Let's begin with an introduction to malaria. At its core, malaria is a fundamentally a parasitic infection transmitted by the Anopheles mosquito. This infection leads to an acute life-threatening disease and represents a substantial global health threat. Its global impact is immense, with 2 billion people at risk annually across 90 endemic countries and among the 125 million international travelers. Annually, between 1.5 and 2.7 million lives are lost to this disease. The Plasmodium parasite's life cycle is notably a multi-stage. This complex cycle is responsible for the characteristic cyclical fevers seen in infected individuals. While most people experience rapid symptom resolution with timely treatment, there is always a risk of significant complications. These can include cerebral malaria, severe malarial anemia, coma, or even death. The specific treatment and prevention regimens are dictated by the Plasmodium species, the geographical location of the infection, known drug, known drug susceptibility, and the patient's individual profile. It's crucial to remember that infection can remain latent and reactivate years after initial exposure. Historically, the term malaria comes from the medieval Italian mala area or bad air, reflecting the old miasma theory. It was also referred to as ague or marsh fever owing to its common occurrence near swamps or marshlands. The term was used in English by 1768. Malaria used to be widespread in many parts of Europe and North America, but it's no longer endemic there, though cases brought in from endemic areas still occur. The study of this disease is called malariology. Delving deeper into the causes, malaria is exclusively caused by a single cell eukaryotes belonging to the genus Plasmodium. In humans, six specific Plasmodium species are responsible for malaria. These are Plasmodium falciparum, Plasmodium malariae, Plasmodium ovale curtisi, Plasmodium ovale valkeri, Plasmodium vivax, and Plasmodium novelsi. Among those infected globally, Plasmodium falciparum is the most common species identified, accounting for approximately 75% of cases, followed by Plasmodium vivax at around 20%. Traditionally, Plasmodium falciparum has been associated with majority of malaria-related deaths. However, recent evidence indicates that Plasmodium vivax malaria can be associated with potentially life-threatening condition just as frequently as Plasmodium falciparum infection. Plasmodium vivax is proportionally more common outside of Africa. While some cases of human infection with Plasmodium species from higher apes have been documented, these are generally of limited public health importance, with a notable exception of P. novelsi. P. novelsi is a zoonotic species that causes malaria in macaques but can infect humans. Malaria is spread exclusively through the bites of infected female Anopheles mosquitoes. The process of transmission occurs when the mosquito bite introduces the parasites from the mosquito's saliva directly into the human bloodstream. From an epidemiological perspective, a significant 40% of the global population either resides in or visits malaria endemic regions annually. The geographic distribution of Plasmodium species varies. P. falciparum is predominantly found in western and sub-Saharan Africa, and it exhibits the highest morbidity and mortality among all the Plasmodium species. P. vivax is prevalent in South Asia, the Western Pacific, and Central America. P. ovale and P. malariae are typically found in sub-Saharan Africa. P. novelsi is concentrated in Southeast Asia. Alarmingly, as many as 500 million malaria cases occur annually, resulting in 1.5 to 2.7 million deaths. A staggering 90% of these fatalities occur in Africa. Several populations are at the highest risk, including children under the age of 5, pregnant women, and disease-naive populations such as refugees in Central and Eastern Africa, non-immune civilian and military travelers, and immigrants returning to their places of origin. Of the 125 million travelers who visit endemic location each year, between 10,000 and 30,000 develop malaria, and 1% of these individuals will die from complications of their disease. Furthermore, rising average global temperatures and changes in weather patterns are projected to expand the burden of malaria. A rise of 3 degrees Celsius is postulated to increase malaria incidence by 50 to 80 million cases. Let's trace the intricate life cycle of the Plasmodium parasite within the human host and the mosquito, which forms the basis of malaria's pathophysiology. The journey begins with infection. This occurs during the mosquito's blood meal. A female Anopheles mosquito inserts her proboscis into human skin and injects up to 100 sporozoids per bite along with her saliva. These sporozoids are remarkably motile, gliding at speeds up to 2 micrometer per second. After waiting period of 1 to 3 hours in the dermis, the successful sporozoids reach the bloodstream. They are then swiftly carried by the blood to the liver, where they must cross the sinusoidal barrier to access and invade their target cells, the hepatocytes. This leads to the exoerythrocytic schizogeny, also known as the liver stage. Once inside the hepatocytes, the sporozoids transition from their migratory phenotype to an invasive one, maturing into spherical multinuclear schizones. After a period of 5 to 21 days, depending on the specific Plasmodium species, each liver schizone ruptures. This rupture releases a large number of uninucleate merozoites ranging from 2000 to 40,000. These merozoids then initiate the erythrocytic schizogeny, the blood stage. At this point, each merozoite has the potential to infect a red blood cell. Inside the erythrocytes, the parasites begin to feed off hemoglobin. Initially, they appear as small, distinct ring forms, which then develop into trophozoites. A key byproduct of the parasite's hemoglobin meal is hemogen, a brown pigment biocrystal waste product. This process is essential for the parasite as it safely disposes of the free radical generating heme molecule which would otherwise be toxic to the plasmodium. These trophozoites further mature back into schizones. These blood stage schizones then rupture, releasing more merozoites, thus continuing the erythrocytic or blood stage of the life cycle. Critically, some trophozoites, instead of developing into schizones, mature into sexual stage gametocytes. These male and female gametocytes are then poised to be ingested by another feeding Anopheles mosquito. Finally, the cycle continues with sporogony, the mosquito stage. When male and female gametocytes are ingested by mosquito during blood meal, they undergo sexual reproduction within the mosquito's gut. This process produces motile eukinids, which then invade the wall of the mosquito's midgut, forming oocysts. The oocysts subsequently rupture, releasing sporozoites. These sporozoites then migrate to the mosquito's salivary glands, where they await the opportunity to infect a new human host, thereby completing the cycle. Moving beyond the life cycle, let's explore the pathogenesis, how the parasite causes disease in human body. Mature trophozoites replicate within red blood cells, forming schizones. The rupture of this schizone destroys the erythrocyte cell membrane integrity, leading to capillary endothelial adherence and cell lysis. Free heme release into the peripheral blood from the breakdown of hemoglobin stimulate endothelial activation. The pathogenesis is further driven by toxin-induced secretion of cytokines, specifically interferon gamma and TNF alpha. The innate immune response is characterized by monocyte and macrophage phagocytosis, predominantly within the splenic red pulp. Adaptive immunity develops through interferon gamma and TNF alpha induced class switching of CD4 positive lymphocytes. Importantly, TNF also suppresses hematopoiesis, directly contributing to anemia seen in malaria. This immune activity combined with parasite presence causes the liver and spleen to enlarge, resulting in massive splenomegaly. Studies have observed low arginine levels, reduced nitric oxide production, and elevated arginine activity in the peripheral blood of severe malaria patients. The parasite's own arginase enzyme is believed to be contribute to this low arginine state in severely ill patients, which in turn reduces nitric oxide production. Low nitric oxide levels can lead to subsequent pulmonary hypertension and myocardial wall stress, particularly in children. This suggests peripheral arginine supplementation or inhaled nitric oxide could be potential treatment options. Parasitemia, the percentage of infected red blood cells, directly dictates symptom onset and severity. Symptoms typically develop with 0.002% parasitemia in individuals with no prior exposure and 0.02% parasitemia in those previously exposed. Severe infection usually manifest with parasitemia levels of 5% or higher. Untreated malaria can last for 2 to 24 months. Furthermore, P. vivax and P. oval infection may exhibit dormant schizogeny, where inactive intrahepatic parasites known as hypnozoites remain dormant until they reactivate months to years later. Although hypnozoite parasites do not routinely develop in the liver with P. falciparum and P. malariae infections, there are few documented reports of resurgence of P. falciparum infection years after initial exposure. The incubation period and thus the time until symptom development varies significantly by species. 8 to 11 days for P. falciparum, 8 to 17 days for P. vivax, 10 to 17 days for P. oval, and 18 to 40 days for P. malariae, though it can be up to several years. 9 to 12 days for P. novelci. The periodicity of Plasmodium life cycle creates the classical malarial paroxysm. This paroxysm consists of rigors followed by several hours of fever, succeeded by profuse diaphoresis, and ultimately a drop to normal body temperature. For example, P. vivax infection typically establishes a 48-hour cycle. However, this classic presentation is less commonly observed today due to rapid identification and treatment. Let's detail the symptoms and signs of malaria. Adults typically experience chills and fever, classically presenting in periodic paroxysmal attacks that last around 6 hours. These attacks are usually followed by a period of sweating and relief from fever, along with headache, fatigue, abdominal discomfort, and muscle pain. Children, on the other hand, tend to exhibit more general symptoms such as including fever, cough, vomiting, and diarrhea. The initial manifestation of the disease, which are common to infection with all malarial parasite species, are similar to flu-like symptoms. These non-specific symptoms can resemble other serious conditions such as sepsis, gastroenteritis, and various viral diseases. The presentation may include headache, fever, shivering, joint pain, hemolytic anemia, jaundice, hemoglobin in the urine, retinal damage, and convulsions. The classic symptom of malaria is these paroxysmal attacks. These are cyclical occurrences characterized by sudden coldness followed by shivering, then fever, and finally sweating. These attacks occur every 2 days, known as tertian fever in P. vivax and P. oval infections. For P. malariae, they occur every 3 days, known as quartan fever. P. falciparum infection can cause recurrent fever every 36 to 48 hours or less pronounced and almost continuous fever. Symptoms typically begin 10 to 15 days after the initial mosquito bite, but can occur as late as several months after infection with some P. vivax strains. Travelers taking preventative malaria medication may develop symptoms once they stop taking the drugs. Severe malaria is usually caused by P. falciparum, often referred to as falciparum malaria. Symptoms of falciparum malaria typically arise 9 to 13 days after infection. Individuals experiencing cerebral malaria frequently exhibit a range of neurological symptoms, including abnormal posturing, nystagmus, conjugate gaze palsy, opisthotonus, seizures, or coma. Malaria can lead to several severe complications. One significant complication is the development of respiratory distress, which occurs in up to 25% of adults and 40% of children with severe P. falciparum malaria. Possible underlying causes include respiratory compensation of metabolic acidosis, non-cardiogenic pulmonary edema, concomitant pneumonia, and severe anemia. Although rare in young children with severe malaria, acute respiratory distress syndrome occurs in 5 to 25% of adults and up to 29% of pregnant women. Co-infection of HIV with malaria also significantly increases mortality. Kidney failure is a notable feature of black water fever, a condition where hemoglobin from live cereal blood cells leaks into the urine, causing it to appear dark. Other potential complications include an enlarged spleen, an enlarged liver, or both, severe headache, low blood sugar, and hemoglobin in the urine coupled with kidney failure. Complications may also manifest as spontaneous bleeding, coagulopathy, and shock. Malaria during pregnancy carries a significant risk, potentially leading to stillbirths, infant mortality, miscarriage, and low birth weight. These outcomes are particularly observed in P. falciparum infection but also occur with P. vivax. Infection with P. falciparum may result in cerebral malaria, a particularly severe form of malaria that involves encephalopathy. Cerebral malaria is specifically defined as severe P. falciparum malaria presenting with neurological symptoms. This can include coma with Glasgow coma score less than 11 or Blantyre coma scale less than 3 or coma that lasts longer than 30 minutes after a seizure. It is often associated with retinal whitening, which can be a useful clinical sign to distinguish malaria from other causes of fever. Cerebral malaria can tragically lead to death within the 48 hours of the first symptom becoming evident. The World Health Organization classifies malaria into either severe or uncomplicated. It is deemed severe when any of the following criteria are present. Otherwise, it is considered uncomplicated. Decreased consciousness, significant weakness such that a person is unable to walk, inability to feed, two or more convulsions, low blood pressure less than 70 mm mercury in adults and 50 mm mercury in children, breathing problems, circulatory shock, kidney failure or hemoglobin in the urine, bleeding problems or hemoglobin less than 50 gram per deciliter, pulmonary edema, blood glucose less than 2.2 mmol per liter, acidosis or lactate levels of greater than 5 mmol per liter, a parasite level in the blood of greater than 1 lakh per microliter in low intensity transmission areas or 2,50,000 per microliter in high intensity transmission areas. Due to the non-specific nature of malaria symptoms, diagnosis is typically suspected based on the clinical symptoms and the patient's travel history. This clinical suspicion is then confirmed with a laboratory test designed to detect the presence of the parasite in the blood, known as parasitological test. In areas where malaria is common, the WHO recommends that clinicians suspect malaria in any person reporting fevers or who has current temperature above 37.5 degrees Celsius without any other obvious cause. Malaria should also be suspected in children who show signs of anemia such as pale palms or laboratory test result indicating hemoglobin level below 8 grams per deciliter of blood. In areas of the world with little to no malaria, the WHO recommended testing only people with possible exposure to malaria, typically involving travel to malaria endemic area and an unexplained fever. Malaria is usually confirmed by the microscopic examination of blood films or by antigen-based rapid diagnostic test. Microscopy, specifically examining Giemsa-stained blood with a light microscope, remains the gold standard for malaria diagnosis. Microscopists typically examine both a thick film of blood, which allows them to scan many blood cells quickly for the presence of parasites, and a thin film of blood, which enables them to clearly see individual parasites and accurately identifying the infecting Plasmodium species. Under typical field laboratory conditions, a microscopist can detect parasites where there are at least 100 parasites per microliter of blood, which is approximately the lower range of symptomatic infection. Microscopic diagnosis is relatively resource intensive, requiring trained personnel, specific equipment, and consistent supply of microscopy slides and stains. Rapid antigen tests are used in places where microscopy is unavailable. These are rapid tests that detect specific parasite proteins in a finger stick blood sample. A variety of RDTs are commercially available, targeting proteins such as histidine-rich protein 2, which detects P. falciparum only, lactate dehydrogenase, or aldolase. The HRP2 test is widely used in Africa, where P. falciparum predominates. However, a limitation is that HRP2 can persist in the blood for up to 5 weeks after an infection has been treated, meaning an HRP2 test cannot always distinguish between a current infection and a resolved past infection. Rapid tests also cannot quantify the parasite burden in a person. While RDs are fast and easily deployable to areas without full diagnostic laboratories, they provide considerably less information than microscopy and can vary in quality between producers and even between different lots. Serological tests designed to detect antibodies against Plasmodium from the blood have been developed, but they are not used for acute malaria diagnosis due to their relatively poor sensitivity and specificity for active infection. Highly sensitive nucleic acid amplification tests have also been developed, but these are not used clinically for routine diagnosis due to their relatively high cost and poor specificity for distinguishing between active and cleared infections. Laboratory findings in acute malaria often include normochromic normocytic anemia. The leukocyte count is generally normal, although it may be raised in very severe infections. There is typically slight monocytosis, lymphopenia, and eosinopenia, followed by reactive lymphocytosis and eosinophilia in the weeks after acute infection. The platelet count is usually reduced to approximately 10 days to 5 per microliter. A normal platelet count may be suggest other diagnosis. The erythrocyte sedimentation rate, plasma viscosity, and levels of CRP and other acute phase proteins are elevated. Severe infection may be accompanied by prolonged prothrombin and partial thromboplastin times and by more severe thrombocytopenia. In an uncomplicated malaria, plasma concentration of electrolytes, blood urea nitrogen, and creatinine are usually normal. Findings in severe malaria may include metabolic acidosis with a low plasma concentration of glucose, sodium, bicarbonate, phosphate, and albumin, coupled with elevation in lactate, blood urea nitrogen, creatinine adjusted for age and body mass, ureate, muscle and liver enzymes, and both conjugated and unconjugated bilirubin. In adults and children with cerebral malaria, the mean CSF opening pressure is lumbar puncture is approximately 160 mm H2O. Usually the CSF content is normal or there may be slight elevation of total protein level and cell count level. Now let's discuss the treatment of malaria starting with uncomplicated cases. For known chloroquine sensitive strains of Plasmodium vivax, P. malariae, P. ovale and certain P. falciparum strains, chloroquine is administered at 10 mg of base per kg immediately, followed by 5 mg per kg at 12, 24 and 36 hours. Alternatively, it can be given as 10 mg per kg at 24 hours and 5 mg per kg at 48 hours. Another option is amiodarone given at 10 to 12 mg of base per kg once daily for 3 days. Radical treatment is crucial for P. vivax or P. ovale infection to prevent relapse, specifically targeting the hypnozoites in the liver. In addition to chloroquine, amiodarone or an artemisinin-based combination therapy, primaquine should be given for 14 days. The dosage for primaquine is 0.5 mg of base per kg QD in Southeast Asia and Oceania, totaling 7 mg per kg over 14 days. In other regions, it's 0.25 mg per kg QD for a total dose of 3.5 mg per kg. It is critical that primaquine should not be given in cases of severe G6PD deficiency. A single dose of tafenoquine 300 mg for adults is being introduced for radical cure in some areas. Alongside quantitative G6PD testing in patients with mild G6PD deficiency, 0.75 mg of base per kg should be given once weekly for 8 weeks, but only if G6PD levels are confirmed as normal. For a P. falciparum malaria, the recommended first-line treatment is artemisinin-based combination therapy. Artesunate 4 mg per kg QD for 3 days plus sulfadoxine 25 mg per kg and pyrimethamine 1.25 mg per kg as a single dose. Or artesunate 4 mg per kg QD for 3 days plus amidoquine 10 mg of base per kg QD for 3 days. Or artemether lumefantrine 1.5 and 9 mg per kg twice daily for 3 days taken with food. Or artesunate 4 mg per kg QD for 3 days plus mefloquine 24 to 25 mg of base per kg either 8 mg per kg QD for 3 days or 15 mg per kg on day 2 and then 10 mg per kg on day 3. Or DHA piperaquine with a target dose of 4 and 24 mg per kg QD for 3 days in children weighing less than 25 kg and 4 and 18 mg per kg QD for 3 days in person weighing 25 kg or more. Second line treatment or treatment of imported malaria if other ACTs are unavailable includes artesunate 2 mg per kg QD for 7 days or quinine 10 mg of salt per kg 3 times daily for 7 days plus one of the following 3 drugs: tetracycline 4 mg per kg 4 times daily for 7 days, doxycycline 3 mg per kg QD for 7 days, clindamycin 10 mg per kg twice daily for 7 days. Alternatively, atoquine proguanil 20 and 8 mg per kg QD for 3 days taken with food. Addressing specific treatment consideration, let's look at malaria during pregnancy. For P. falciparum malaria, in the first trimester, oral quinine salts are the treatment of choice. In the second and third trimesters, artemisinin-based combination therapy is recommended. For P. vivax malaria during pregnancy, chloroquine remains the drug of choice. In cases of mixed infection, specifically with P. vivax and P. falciparum, the recommended regimen is artemisinin-based combination therapy for 3 days combined with primaquine for 14 days. Severe malaria constitutes a medical emergency requiring immediate and intensive treatment. The primary treatment is artesunate administered intravenously at 2.4 mg per kg state, followed by 2.4 mg per kg at 12 and 24 hours, then daily if necessary. For children weighing less than 20 kg, a dose of 3 mg per kg per dose should be given. If artesunate is unavailable, artemether can be given intramuscularly at 3.2 mg per kg state, followed by 1.6 mg per kg once daily. If neither artesunate nor artemether is available, quinine dihydrochloride is an option. 20 mg of salt per kg infused over 4 hours, followed by 10 mg of salt per kg infused over 2 to 8 hours every 8 hours. Beyond anti-malarial drugs, the management of complications of malaria is critical. For cerebral malaria, this condition usually renders the patient comatose. If the cause of the coma is uncertain, testing for other locally prevalent causes of encephalopathy such as bacterial, viral or fungal infection should be conducted. In high prevalence malaria areas, treatment can begin without initial testing. To manage confirmed cerebral malaria, meticulous nursing care is essential, including monitoring vital signs, turning the patient every 2 hours and preventing wet beds. A sterile urethral catheter should be inserted for urination and sterile nasogastric tube for aspirating stomach content. In the event of convulsions, a slow intravenous injection of benzodiazepines is administered. For acute renal failure, if plasma levels of blood urea nitrogen or age and weight adjusted creatinine rise despite adequate rehydration, fluid administration should be restricted to prevent volume overload. As with other forms of hypercatabolic acute kidney injury, renal replacement therapy is best performed early. Hemofiltration and hemodialysis are more effective than peritoneal dialysis and are associated with a lower mortality risk. Some patients with renal impairment pass small volumes of urine sufficient for fluid balance control. These cases can be managed conservatively if other indications for dialysis do not arise. Renal function typically improves within days, though full recovery may take weeks. For acute pulmonary edema or acute respiratory distress syndrome, this syndrome is caused by increased pulmonary capillary permeability. Patient should be positioned within the head of the bed elevated at 45 degree and given oxygen and intravenous diuretics. Positive pressure ventilation should be initiated early if immediate measures fail. Rarely, patient may require extracorporeal membrane oxygenation. For hypoglycemia, an initial slow intravenous injection of 20% dextrose 2 ml per kg over 10 minutes should be followed by an infusion of 10% dextrose 0.10 gram per kg per hour. Blood glucose levels must be checked regularly thereafter as recurrent hypoglycemia is common, particularly among patients receiving quinine. In severely ill patients, hypoglycemia commonly occurs alongside metabolic acidosis and carries a poor prognosis. For a sepsis in malaria endemic areas where a high proportion of children are parasitemic, distinguishing severe malaria from bacterial sepsis with confidence is often impossible. These children should be treated with both antimalarials and broad-spectrum antibiotics with activity against non-typhoidal Salmonella species from the outset. Ideally, all patients with severe malaria should have blood cultures taken, and empirical antibiotics should also be given to adults with over 20% parasitemia. Antibiotics should be considered for severely ill patients of any age who are not responding to antimalarial treatment or who unexpectedly deteriorate. For other complications, patients who develop spontaneous bleeding should be given fresh blood and intravenous vitamin K. Convulsions should be treated with intravenous or rectal benzodiazepines and, if necessary, respiratory support. Aspiration pneumonia should be suspected in any unconscious patient with convulsions, particularly with persistent hyperventilation. Intravenous antimicrobial agents and oxygen should be administered and pulmonary hygiene undertaken. There is insufficient evidence to show that blood transfusion is useful in either reducing deaths for children with severe anemia or in improving their hematocrit in 1 month. Furthermore, there is insufficient evidence that iron chelating agents such as deferoxamine and deferiprone improves outcomes for those with P. falciparum infection. The successful management of severe malaria demands a multidisciplinary approach, continuous monitoring, and the ability to rapidly respond to evolving clinical situations. Chemoprophylaxis involves taking antimalarial drugs to prevent infection from developing. The choice of agent depends on the travel destination, duration, resistance patterns, and individual patient factors. For short-term prophylaxis, defined as travel duration less than 6 weeks, the drug of choice is doxycycline at 100 mg daily. This should be started 1 to 2 days before travel and continue for 4 weeks after returning. For long-term prophylaxis for travel duration exceeding 6 weeks, the drug of choice is mefloquine at 250 mg weekly. This medication should be started 2 to 3 weeks before travel and continue for 4 weeks after returning. Effective prevention is paramount in the fight against malaria. Individuals traveling to malarial regions must be provided with adequate information regarding prevention strategies as well as tailored and effective antiprotozoal medications. Avoidance strategies are also critical. This includes avoiding mosquitoes by limiting exposure during times of typical blood meals, which are primarily dawn and dusk. Wearing long-sleeved clothing and using insect repellents can also prevent infection. It is also advised to avoid wearing perfumes and colognes which can attract mosquitoes. Mosquito nets play a vital role. Bad nets treated with insecticide are more effective in protecting against malaria compared to untreated nets. The insecticides not only kill but also repel mosquitoes, thereby reducing the number of mosquitoes that enter houses and attempt to feed on people. When community coverage with these nets is high, the overall mosquito population and their lifespan are reduced, providing protection to all members of the community. It is recommended to consider using bed nets that are treated with an insecticide permethrin. While this is an effective method of preventing malaria transmission in endemic areas, there has been an increasing incidence of pyrethroid resistance reported in Anopheles species. For mosquito repellent, lotions containing DEET at 34% concentration, such as Ultrathon, which was developed for the US military, provided up to 12 hours of protection. Lotions with picaridin 20%, such as Shoyer, may provide up to 14 hours of protection. Picaridin has the added advantage of being odorless and non-greasy. Both DEET and picaridin are considered safe for pregnant women and children over 2 months old. As noted with bad nets, the synthetic pyrethroid permethrin can also be sprayed on clothing, tents, and sleeping bags. Permethrin impregnated clothing is also available on the market. Wearable devices like wristbands containing various repellents have not been consistently shown to be particularly effective in reducing mosquito attraction. Furthermore, if staying for prolonged periods in high risk malaria endemic areas over 6 months, topical repellents alone have only slight efficacy in lowering the overall malaria prevalence. Finally, regarding illness, although there is a high risk of febrile traveler's diarrhea whenever traveling to low resource setting, if fever does not abate with treatment, immediate medical attention should be sought as malaria may present with febrile diarrhea in almost half of cases. It's vital to remember that no single prevention strategy is 100% effective. Therefore, a combination of personal protective measures along with appropriate chemoprophylaxis offers the best protection. If fever or flu-like illness occurs during or up to 1 year after travel to an endemic area, immediate medical attention is necessary and travel history must be disclosed. This comprehensive approach to prevention significantly reduces the risk of contracting malaria. The development of malaria vaccines has been significant goal of research for decades. The first promising studies demonstrating the potential for malaria vaccine were performed in 1967. These studies involve immunizing mice with live radiation attenuated sporozoites which provided significant protection to the mice upon subsequent injection with normal viable sporozoites. The first vaccine to receive approval was called RTSS. It was approved by European regulators in 2015. As of 2019, this vaccine was undergoing pilot trials in three sub-Saharan African countries, Ghana, Kenya, and Malawi, as part of the WHO's malaria vaccine implementation program. By 2020, the RTSS vaccine has demonstrated a reduction in the risk of malaria by about 40% in children in Africa. More recently, Germany-based BioNTech SE is developing an mRNA-based malaria vaccine, BNT165. This vaccine has recently initiated a phase 1 study in December 2022. The BNT165 vaccine, which is based on the circumsporozoid protein, is currently being tested in adults aged 18 to 55 years at three different dose levels to select a safe and tolerable dose for 3-dose schedule. Another significant advancement is the R21 Matrix M malaria vaccine. This vaccine was found to reduce cases of malaria by 75% in areas with seasonal spread and by 68% in areas of year-round spread among children in sub-Saharan Africa. The R21 Matrix M malaria vaccine was officially endorsed by the WHO for the prevention of malaria in children in 2023. As of 2023, two malaria vaccines have been licensed for use, RTSS and R21 Matrix M. These vaccines are being rolled out with 20 countries having introduced them into their routine immunization programs as of April 2025 and further for planning to do so by end of 2025, marking a crucial milestone in malaria prevention. This progress highlights the dynamic and hopeful areas of research in the global health community. This concludes our detailed overview of malaria. I hope this comprehensive look at its etiology, epidemiology, pathophysiology, treatment, and prevention strategies provides you with a robust foundation for your medical practice. Thank you for your attention, guys. If you have any further questions, please feel free to reach out and please like, share, and subscribe to the Docsaab's Diary. Thank you. Thank you.